Edge. Edge in my yard.
Okay, so your slide, I think it's like number 40. Just completing what it says here is caring for the woman with incompetent cervix. She had, as we talked about already, she has what you know, she has ruptured membranes, any kind of labor contractions or signs of infection. Okay, this is a cerclage. And the type of birth that she has, depending on what procedure they use on the patient, if they choose to leave the sutures in place, they'll do a cesarean birth on her. If they choose that she wants to try to do a vaginal birth, you want to, the sutures are usually removed around 37 weeks gestation so that she doesn't go into preterm labor. Okay, so they'll remove those. And again, we always seem to have the case where they remove them around 37 weeks of gestation, and then they have to induce them for some reason. Like they go beyond what they you expect them to go. You think that they're going to preterm labor, they usually go out and don't. The next thing I'm going to talk about is placenta previa. Okay, and again, that's the slide you have. There's placenta previa. Now think about how pretty. Somebody had asked me of course the way about there's a difference between previa and eruption. And they always try to influence, try to make you remember this. Placenta previa sounds pretty nice, okay. All right, so there's different types of placenta previa. What this really means is the placenta implants not in the correct place in the uterus. Okay, so the different categories they have is a total placenta previa, meaning that there's no exit, that the entire internal os is covered by the placenta. Okay. So here's a picture of a total placenta previa. So normally the placenta is normally around up here, right? And for some reason, maybe scar tissue, couldn't implant where it should have. Okay, maybe the woman had a C-section and didn't wait like a year to get pregnant again, and maybe healing didn't occur as well as it should have, so she might be a little scarred. So the placenta can go different places. And this is called a complete previa, because here's the cervix, this is the whole placenta, and it's completely covering, see how it's covering the exit, the os, the cervical canal. So the baby cannot come out vaginally. You see that? Because this is, right here is covering the baby's exit. The exit, that's covering it. So complete previa is that the placenta is totally covering the exit for the baby, or totally covering the os, so that the baby cannot come out. What they'll do is schedule a cesarean section, okay? And this way, the woman won't go into labor, and the labor causes a bleed, and this, as I said, the baby's not able to get out that way. Okay. And then we have the partial previa. The internal os is partially covered. We have the marginal one. The edge of the os is covered. And then the low-lying placenta is implanted in the lower segment in the proximity to the os, but not covering or touching. Okay, so the pictures will show you. This one here is a low placental implantation. We can see in this case here, this is just barely touching the os. The os is where the internal os is here, external os is here. Just now. Okay. One might mistake come out vaginally. This is no restriction. That's one of the ways to look at the other one. This one here is a partial placental previa. Okay, it was partially covering the whole os. But as compared to the picture, it was completely all right up here. And then here is that. And then sometimes they just have some, as I said, a low line one is touching it, but not disrupting the baby from coming out of that. All right, so what causes this? Again, not everybody really knows, but a lot of times it could be the fact that maybe she had a C-section and she's having, gets pregnant before the section, incision heals right, so there might be some scar tissue, so that something can't implant there. They have different classifications for this. I think this is from the last, from the older book. This was taken from the figures. But you just look up the preview. I was looking at the new book. It's interesting. The new book has all this in one, in chapter 18. And then it used to be centipede and some other stuff is like another chapter from the old book. If you just look up the name centipede in your textbook and you'll find the chapter where it's located. So the older book has it in a different place. So it might be figure 19-4. So what we have is therapeutic management depending on the bleeding, the amount of placenta that's covering the os, the fetal development and position of the fetus, the maternal parity, meaning how many times she's pregnant, labor signs and symptoms. Okay, so nursing assessment, we assess for risk factors. One of the ways that is very classic symptoms is painless, bright red vaginal bleeding. And that's a classic symptom of previa, placenta previa. So it's painless, bright red vaginal bleeding in the second or third trimester, and spontaneous sensation that then returns. So what happens is it will bleed. She wakes up in the morning, she's not feeling any pain, and she's in a pool of blood. Okay. Then, of course, that scares the heck out of anybody, who's pregnant. So she calls the office, and they tell her to come in, and do an ultrasound on and all that. Then what happens is, just on its own, sometimes it just doesn't bleed anymore. Maybe it'll start bleeding again 10 weeks later. Okay, so it's really a watch and see kind of thing. They would take her H&H to make sure she's not bleeding too much. But a lot of times it happens and then it doesn't happen again until she is more towards term. Okay, so show you that. Okay. Risk factors, she had a previous placenta previa, multiparity, having more than one child, increased maternal age, and placenta accreta, which is when the placenta itself gets buried into the uterine wall. Okay, it's abnormal. So, again, it could be somebody had a C-section, it's not totally healed, the woman gets pregnant, and the placenta will be part of the scarring process and get into the uterine wall, and that's an accreta. Okay, so risk factors for placenta previa, there might be a defective decidual blood vessel, which is really what's inside the uterine wall, a large placenta, smoking and cocaine use in pregnancy, a previous cesarean section, previous abortion. I don't know why a male fetus, maybe, who knows. They come up with these things every now and then, so somehow some statistics must have shown that, And then multiple gestation. Implications for placenta previa, maternal psychological stress. Anytime you see vaginal bleeding when you're pregnant, especially when there's a lot, is a very stressful situation. Sometimes the baby is a transverse lie, meaning that they are not in the right position. Okay, so that can cause that. Okay. There could be a change in heart rate. There could be meconium, staining when she goes into labor, meaning the baby is stressed. Whenever you see a baby that is pooped in utero, usually means the baby is stressed in some way, maybe hypoxic. Okay. Immunocompromised, cesarean birth can occur, and there might be neonatal anemia just because of the blood loss. Expected management, bed rest with bathroom privileges while not bleeding. While she's not bleeding, she can get out of bed, okay, go to the bathroom. No vaginal exam. Now, this is always something very important to remember. This is a test question. No vaginal exams. Why? Because if you go in there and she has a complete previa and you go not knowing this, you can actually put your hand right where the placenta is and pull it away from the wall and cause the woman to hemorrhage and the baby not to get blood. That is optional matter. So you don't go in and do a vaginal exam on a person who's bleeding unless you know what's causing the bleeding. Any kind of vaginal bleeding, particularly second, third trimester. Okay, you don't want to be disruptive there. You want to monitor any blood loss. Perhaps you'll be wearing peri pads. You know, you learn how many she goes through. Any kind of pain, because it's usually she doesn't have pain, because it's painless. Any uterine contractions. Evaluate the heart rate, the moms and the babies, and the vital signs of the mother, especially expecting management. Lab evaluation, you gave her H&H, and again, this will be on your third test and on your file. You always have to know the CBC, normal amount. What her RH factor is, because if she's RH negative and she's bleeding, they will give her Rogaine within 72 hours of that bleeding. Okay. IV fluids, lactate Ringer's solution. Again, when you bleed, when you hemorrhage, you are very thirsty and very dehydrated. You have available 2 units of plasmatic blood available just in case she does hemorrhage. So you have to get her blood type. I didn't have that just available just in case she hemorrhages. Okay. Nursing diagnosis for placenta previa, fluid volume deficit related to hypovolemia, secondary to excessive blood loss. Risk for impaired fetal gas exchange related to decreased blood volume and internal hypotension. Anxiety related to concern for personal status and baby safety. Okay. The plan, no vaginal exams. If anybody gets that wrong on the test. But again, we did have somebody say that nitrazine terms were not good.
Damn.
You like to hammer your nuclear heads. Doesn't always work.
It was me.
Okay.
I'm just kidding.
Right, so, objectively and subjectively assess blood loss, any pain level, any uterine contractions. Continue external monitoring of the fetus and uterine activity. No internal monitoring. Again, that goes along with no, vaginal exams. Okay. Monitor mom's vital signs, intake and output. Every 5 to 15 minutes with active hemorrhaging and obtain labs. Okay, so she's actively hemorrhaging. You're going to keep an eye on for hypovolemia. Okay, which of the following would the nurse expect to assess in a woman with placenta previa?
D.
What do you think?
That was D, yo.
Okay, J. The woman with placenta previa would have a soft, relaxed uterus. Okay, no pain, soft, relaxed uterus, accompanied by a painless, bright red vaginal bleed that stops spontaneously only to recur some other time. Abruptio placenta, we'll talk about next, is associated with dark red vaginal bleeding, uterine tenderness, and fetal distress. Okay. You'll have the slides. Okay, so abruptio placenta. Now, doesn't that sound not as pretty as previa? And when you think that, I go, abrupt. So you know it's not good. So this is abrupt. Everybody remember that. And even people who took tests on OB, said, I remember you saying abrupt. And I remember it because of that. Whatever it is, right? So abruptio placenta is much more of an emergency. Okay? This is a separation of the placenta leading to compromised fetal blood supply. Unknown etiology. They do, some people who come in with motor vehicle accidents, okay, if the airbag goes off and they're pregnant, this can cause the separation of the placenta from her uterus. Okay, that's one thing. Somebody punches her in the stomach. That also can cause this to occur. Cocaine can cause this to occur. It causes constriction of the blood vessels to the uterus, to the placenta, for separation. Okay, so some of those things are possible causes. The classification, 19.5, again, it's textbook. Therapeutic management is assessment, control, and restoration of blood loss, positive outcome, I told before, and prevention of something called DIC. Okay. Contributing factors to rupture of placenta. Hydramnios. So again, what is hydramnios or polyhydramnios? Too much. Too much amniotic fluid. Okay. We had a patient last week who had hydramnios, a history of ectopic pregnancy. There's like a whole bunch of things this one had. She was like, 38. Yeah. Okay, so anyway, so hydramnios means too much fluid. Or they used to call it polyhydramnios, which means too much fluid. Oligohydramnios means too little, like oliguria, from okay, so multiple gestation, maternal hypertension again constricts the blood vessels. Cigarette smoking constricts the blood vessels. Alcohol ingestion, I don't know why, maybe she'll fall on her stomach, I don't know. Trip and fall. Yeah. Cocaine ingestion, again, that is constriction of the blood vessels. Okay. Increased maternal age and parity, trauma, domestic violence. If the baby is non-vertex presentation, so it's a breech or transverse. Sudden changes in intrauterine pressure, such as having an amniotomy, when they artificially rupture the membranes. Also, there's a lot of fluid, the amniotic fluid is pouring out there, so that's a change in pressure. Okay, types of abruption. Okay, marginal abruption is the placenta separates at its edge. The blood passes between the fetal membranes and the uterine wall, and blood will escape vaginally. Okay. Central type of abruption is the placenta separates centrally. The blood gets trapped between the placenta and the uterine wall, and there's concealed bleeding. Okay, so one is allows the blood to escape. Marginal, central will conceal the bleeding. Okay, so here's some pictures here. This is a marginal abruption with external hemorrhaging. Okay. So the abruption is, this is the placenta. See how it's against the uterine wall? And this is marginal because you see here, it's pulled away from the uterine wall right in this area here, you see the blood. Okay. Right there. Okay. So because of the way the tear is, this bleeding will come out vaginally, and you'll be able to see that the person is bleeding that way. Okay. This one here is a central abruption with concealed hemorrhaging. So it's in the center of, see how it's right here, and there's no edges that allows the blood to come out. So it stays here, and the bleeding keeps going between the placenta and uterine wall. What happens with that is that the classic signs and symptoms of abruption is that the uterus is hard as a rock. It's like board-like, right? Very hard because of the bleeding. There's no escape of the blood. So you feel the person's fundus or uterus is going to feel very hard. There's a lot of pain associated with this particular condition. Okay, really, very painful, they'll say. And particularly with this, central abruption there, what happens is it becomes even more painful, the hardness of the abdomen, and let's say they were in a car accident, and you suspect perhaps they might have an abruption. What I used to do is I would feel where I could feel the fundus of the uterus, okay, and let's say right below or around the diaphragm area of the patient. I would put a pen mark where the fundus was when she first comes into the emergency room or L&D. Okay, an hour or a half hour later, you go to check on the patient, probably quicker than that, you check on the patient, and all of a sudden, because of this bleeding, the bleeding might continue, all the way up here. The fundus is going to be higher up because it's bleeding inside. Okay, so the fundus will start to get higher up in the cavity because of the bleeding inside. Okay. And then the fluid separation. would be that the this whole placenta is totally torn away from the wall. Okay, totally away from the wall. So the only time I've ever seen a mother and baby die, okay, was my first day when I was a junior student, Sibley Hospital, right outside Washington, D.C. And it was my first day, and I was just like twirling around, community hospital, whatever, And this, an ambulance comes in. It's an Indian woman, okay, from India, and so she comes in, and she didn't look really well. But I don't know, maybe say dumb. I was dumb my first day, it was the rotation. So they like, come on back and get to see a C-section, And what happened was she was in an automobile accident, and it must have been, they didn't have air guns back then, and it must have been some kind of blunt trauma to her, abdomen, and she was bleeding out of her nose, out of her IV, out of everything. Okay, and the baby was a complete rupture, so that meant that there was nothing attached to the uterine wall. The placenta was totally pulled away. So what does that mean for the fetus? It's not getting anything, right? That's their lifeline is right there. So they tried to get the baby out as fast as they could. The baby was dead, because of the abruption, no oxygen. And then the mother started to get something called DIC. Coagulation. Right. Anyway, what happens with that is you start to, get all the clotting factors to try to clot, and then they get depleted. So now there's no clotting factors because the woman's hemorrhaging so much that they're running out of clotting factors. So this DIC occurs where they keep bleeding and there's no clotting factors. And the woman anybody will start to bleed out of their IV site, out of their nose, if you gave them any place, she was bleeding everywhere. Okay, she died. And that was my first day of clinical. And I thought to myself, wow, does this happen often? And I've never seen it again. So I've never seen it again. So that's why when I say abrupt, this can be very detrimental. It's an emergency situation, and you got to, respond quickly to this. Okay, so nursing assessment risk factors. What you're going to see is dark red bleeding. If it's coming out, it's marginal. The pain is knife-like. Okay, so this is abrupt, painful, hard uterus. Okay, uterine tenderness. You may have contractions. You're going to decrease in the fetal movement and activity. You're looking at the fetal heart rate to see if there is still a fetal heart rate. The laboratory findings, you go and get the CBC. Okay, that would give you the H&H. Fibrinogen levels, PT, PTT, type and cross match. Okay, so those ones in the middle there are to see the bleeding factors or clotting factors. And then you have to have the type and cross match of the blood. Okay. Maternal implications for abruptio placental of the placenta. She could have intrapartum hemorrhage, DIC, what's the other book? Again, hypofrac, again, she's not going to have a lot of fibrinogen. A ruptured uterus from overdistension if she's bleeding into her uterus. And then she could also have fatal hemorrhagic shock. Nursing management, tissue perfusion, left lateral position, strict bed rest, oxygen therapy, vital signs, fundal height check, continuous monitoring. You want to be supportive, education, empathy, understanding, explanation, and possible loss of the fetus can occur. And there's, she can also reduction of reoccurrence. So they're hoping that it doesn't happen again if this fetus even survives it. Okay. So some of the postpartum complications, she can have vascular spasms, intravascular clotting problems, hemorrhage, renal failure as part of the whole hyperbilirubinemia, and then she goes into shock. Okay, those are possible. Clotting studies, values in DIC. So if you were to do a DIC panel, you would find a decrease in her fibrinogen levels, a decrease in her platelets, prolonged PT and prolonged PTT, and then the increase in the fibrinogen degradation products. Okay. Does that make you a little excited? Makes you want to run around. All right, this is the last one we'll talk about, then I want to just talk about those case studies. Okay. Hyperemesis gravidarum. This is a severe form of nausea and vomiting. The Duchess of York, wherever she's from, Duchess of whatever, Kate, okay. She has a hyperemesis gravidarum in her pregnancy. She was about two and a half months along the pregnancy, and they had a hospitalizer. Okay, so if you don't know who that is, that's the one who married Prince
Charming.
William. Thank you. I should know why it's not. Okay, so a hyperemesis. So it's severe form of nausea and vomiting. It's not even morning sickness. Morning sickness is you don't a little bit of waves, nausea, maybe vomit. You know, usually that's finished by the time you're going into about 13 weeks pregnant. Usually that morning sickness goes away. This goes beyond that, where you can't keep anything down. Okay, your weight loss is greater than 5% of your pre-pregnancy body weight. You become dehydrated. You can get metabolic acidosis, alkalosis, and hypocalcemia. Some of the management is to start at home first with a diet, conservative diet, and lifestyle changes. So again, they start almost like they do with a person with morning sickness. Crackers in the morning, nothing that affects, you know, it's too smelly or too, you know, ugly to look at. When you're pregnant, it makes you nauseous. So they'll be conservative, you know, not a lot of greasy, fat foods. Okay. Then, if that doesn't work and she's still not keeping anything down, she'd have to be hospitalized and perhaps with parental therapy. Nursing assessment, onset, when did it occur, how long does it last, course of nausea and vomiting, does she keep anything down, or does everything just come up, diet history, any risk factors, she has to be weighed, associated symptoms, perception of the situation. It used to be, when the men were in charge, that they'd say it's all psychological. So now they're saying, you know, there could be causes. Sometimes if you have, some people are very receptive to, if they have an increase in the hormones in their body, HCG, you know, or estrogen or progesterone, that can cause them to get nauseous a lot of times. Sometimes if you're carrying more than one fetus, you're going to be more nauseous because you have more hormones carrying twins. Okay. You're going to take a look at the liver enzymes, also do a CBC, a BUN for kidneys and electrolytes, just to see how everything is, so that they're trying to rule out any other problems that might be going on. Comfort and nutrition, the first 24 hours after she's admitted, okay, everybody hear me? This is a test question. Those of you on YouTube, get off it. Facebook. All right, so test question, okay. So she comes into the hospital because she can't keep anything down. The first 24 hours, what they'll do for her is give her an IV, okay? So she's hydrated. But they'll keep her NPO, meaning nothing, she can't have anything to eat or drink, for 24 hours just to get her stomach calmed down, okay? So she'll be on an IV, but she'll have nothing to eat or drink. Oral hygiene will be done, I&O will be done on her. After she is there for 24 hours, they will very slowly introduce a very bland diet and see how she does with that. Okay. Support, education, reassurance, home follow-up. A lot of times, you know, they want to get the insurance company wants you out of the hospital as soon as they can get you out of the hospital. They might provide her with some antiemetics, which will control the vomiting. They'll provide IV fluids, provide hydration. They'll try to restore her electrolyte balance, add potassium chloride to her IVs, provide her with thiamine, administer vitamin B6, and then maybe if it comes down to it, you have to give her total parental nutrition, okay, if it comes down that she's still not holding it down. Okay. Then you want to assess the amount and character of hormesis, monitor I&O, see how her emotional status is, try to provide a relaxed and quiet environment, minimize the food odors, provide oral hygiene, and monitor her weight up daily. The other thing is they do have some people say to use ginger, and you put some ginger with tea. Sometimes that stops some of the nausea also. What is that? Salt on your tongue. There's things out there, again, the things for morning, for emotion, and stuff like that. I do know, like, my niece was getting injections of B6 and B12 to see if that would make a difference. So, okay. All right, so we'll stop for now, but I want to everybody get together in their